most of the things I would have talked. Second, time is short. So I will only highlight the certain aspects. I am asked to talk about treatment algorithms and practical approach to heart failure treatment with ARNI. So firstly, I will talk about acute heart failure. Acute heart failure is nothing but a rapid onset of symptoms and quick worsening leading to hospitalization, and it's a leading cause of hospitalization and in-hospital mortality. And even post-discharge, in 1 year, there can be as many as 25 to 30% mortality. All the acute heart failures are not the same. There are 4 clinical types. One is acutely decompensated heart failure in a previously chronic heart failure, or acute pulmonary edema, or isolated right ventricular failure, and cardiogenic shock. Whatever may be the clinical profile with which it is presenting, the treatment is more or less similar except for the minor differences. For example, in cardiogenic shock, you won't give diuresis, and in acute pulmonary edema, probably inotropic agents have not much role. But it's important to realize what is the syndrome and appropriate management can be done. The algorithm for acute heart failure management is, first, you should do basic testings. And of course, natriuretic peptide testing is a very important step to rule out heart failure when the BNP is less than 100 or anti-pro-BNP is less than 300. You have to look for other causes of acute dyspnea, not heart failure. Or if there are more than 100 of BNP or more than 300 of anti-pro-BNP, then you are justified in treating it as acute heart failure. So this is the first step after the basic tests, including chest X-ray. Nowadays, lung ultrasound is an important tool which is used in critical care units to look at pulmonary edema. And as Dr. Raju has already told, several of the investigations are recommended, but they can be modified according to the availability and their utility. For example, if you are suspecting sepsis, you have to do procalcitonin. Especially this confusion is more seen in this COVID pandemic days, where many times we are not very sure whether it's heart failure or COVID pneumonia or bacterial pneumonia like that. And certain investigations like iron status is now become class 1 indication, and every case of heart failure should have iron status. Lactate is also very important parameter, and of course ECG, echo, and natriuretic peptides. So there are 3 stages in management of acute heart failure. First is the immediate management of stabilization, then intermediate management to identify the etiology and think of various higher advanced therapies like device therapy or revascularization or some other treatment. Pre-discharge, all cases should be evaluated. This is the time when you should again look at iron studies and give intravenous iron therapy and stabilize, then enroll the patient into a particular disease management program. And this aspect is already talked about. Oxygen is to be given if SpO2 is less than 90. Intubation where recommended, where needed, and IV loop diuretics is the primary treatment, class 1 therapy, and thromboembolism prophylaxis. These are all class 1. You should understand that inotropes are not recommended routinely in all the cases. It should be used sparingly. And rational use of opiates, routine use is not recommended. And IABP is not routinely recommended in all the post-MI cardiogenic shock. There are new trials telling that IABP may not be helpful. Then coming to the follow-up of the hospitalized patient, this is the time when you have to introduce all the guideline-proven therapies, including ARNI. ARNI has become an important therapy which should be introduced as early as possible after stabilization. So there is a trial known as transition trial which has shown that earlier you introduce the ARNI, you will have better benefit in the long term. And what are the algorithm for chronic heart failure? When a patient is coming with clinical signs and symptoms, the first step is, of course, natriuretic peptides. The cutoffs you can remember, NT-proBNP more than 125 or BNP more than 35 is the first step. Then, of course, you do a good echocardiogram to label it as either one of the three important subgroups of heart failure. So this is already emphasized by my previous speakers. And what are the new changes in the new guidelines about chronic heart failure? One is, instead of mid-range, the word is replaced by mildly reduced. And diagnosis of mid-range EF is very important to have natriuretic peptides and any other evidence of structural heart disease. Especially, you have to look at LV mass, left atrial sizes, and any other evidence of increased LVEDP. This is very important way to look at the other than reduced ejection fraction. Those groups, this evaluation is very important. So this is already covered by Dr. Naveen, which I'll skip. About heart failure with preserved ejection fraction is very much well described by Dr. Jagdish, and we have to remember that the mortality is almost 10 times more than those who have other types of heart failure. So it is very important segment. This should not be neglected, and you have to remember that there are various risk factors like advanced age, systemic hypertension, atrial fibrillation, female gender, kidney disease, metabolic syndrome, obesity, and COPD, sleep apnea disorder, pulmonary hypertension. All these things should make you alert to the probability of having heart failure with preserved ejection fraction. So one should have very low threshold for doing very detailed echocardiogram to look at diastolic dysfunction in a case of suspected heart failure with preserved ejection fraction. And there are three stepwise approach, that is initial workup, then diagnostic workup, then advanced workup, like diastolic stress test is recommended for advanced workup. And of course, cardiac MRI is very important, which has been emphasized. And in some cases, you may have to do genetic studies or scintigraphy and PET. This has, though not talked about directly, for heart failure with preserved ejection fraction, we have got functional criteria and morphological criteria, biomarker criteria, whether in sinus rhythm or atrial fibrillation. Basing on this, a particular points, major criteria and minor criteria, basing on this, it is defined as to how to identify heart failure with preserved ejection fraction. Coming to the diagnostic algorithm, this is already emphasized by Dr. Raju. It has shown that it is class 1 recommendation to do natriuretic peptides, ECG, echo, chest X-ray, and tests for the comorbidities, and CMR, and invasive coronary angiogram if there is angina as a symptom. And if somebody has heart failure, heart transplantation, or mechanical circulatory support systems in their program, probably that is a place where you have to do cardiopulmonary exercise testing and, if needed, right heart catheterization. Then the algorithm for treatment, this is already shown, this slide is already shown. There are 5 pillars for treatment of heart failure with rejection, reduced ejection fraction. AC inhibitors are ARNI, beta blockers, MRA, and DAPA are the SGLT2 inhibitors, and diuretics. So these are called 5 pillars of treatment for heart failure. And basing on ejection fraction and QRS duration, where it is indicated ICD can be a class 1 indication, or CRT can be a class 1 indication depending on the QRS width. And coming to the ARNI, I'm asked to talk about ARNI in particular. A few things are maybe repetitive, but you can note that there is evidence to say that ARNI is the first line of treatment for class 3 heart failure with reduced ejection fraction. And in fact, it is recommended that if somebody is stable on ACE inhibitors or ARBs, it is still recommended that it can be replaced by ARNI in ambulatory patients who are symptomatic despite optimal therapy. So it is not wrong to replace a stable patient on ACE inhibitors or ARB to be replaced with ARNI. And it should not be used in patients with angioedema. And those who are previously on ACE inhibitors, the drug should be stopped at least 36 hours before the first dose of ARNI. And either it can be used, preferably it should be used in hospital just on the day of your shifting to the pool wards from ICCU. As a thumb of rule, you have to look at systolic blood pressure, whether in the last 6 hours it is more than 100 or not, and diuretic dosage is stable and you are not titrating up or down, and no intravenous vasodilators are being given, and that is the stage when ARNI can be introduced. And it also can be used de novo. That means if somebody is not on ACE inhibitors or ARBs before, there is still a place for starting it directly. And what is the specific order in which it should be introduced along with the beta blockers, that is left to the discretion of the clinician. In OPD, you can give a starting dose of, if somebody is on less than 10 milligrams of enalapril, probably you can go for 24/6/26. That means there is 50 milligram twice. If somebody is already receiving more than 10 milligrams of enalapril, probably you can go directly to 100 milligram twice. So for the starting dose, you have to look at what is the ACE inhibitor dose he is getting, or if he is on ARBs, you should look for valsartan equivalent dose. If somebody is taking less than 160, then you can start at 50 milligram twice. If somebody is more than that, probably you can go for 100 milligram twice. And is it okay to start simultaneously with MRA? Probably if you have lab facility to monitor potassium, you may start very carefully. What about using very low dose? If somebody has chronic kidney disease or potassium levels which are at the upper limit of the normal, probably you can use much lower dose than usual setting. What is the target dose? You have to reach 100 milligram twice. Dr. Raju has beautifully highlighted this point that we always give lesser than the recommended target dose. That is so for ARNI also. One may be the cost factors. Second is lack of knowledge with the physicians who are following our cases. So up titration is performed every 2 weeks, and at every visit when you are doing up titration, it is better to look at GFR and creatinine, and it should be maintained or up titrated even if the blood pressure is somewhat less than before. If the patient is not experiencing any bad symptoms or there is no evidence for organ hypoperfusion, you can up titrate. So it is always effort should be made to go to the target doses of ARNI for the best results. What about the second line drugs, ivabradine, hydralazine, and digoxin, and vericiguat? These are some of them. This is a very new drug, may not be available in India, I'm not very sure, but it is available in the West, and it is also FDA approved. Ivabradine is now very much available and is being used. You should know the specific indication. Digoxin has very limited role, and this is vericiguat, which Dr. Raju has already told. It acts like nitric oxide, ultimately reducing the inflammation, decreasing the fibrosis and hypertrophy, and increasing the renal blood flow. And the phenotypic approach, what it means, in a case of chronic heart failure, you have to look at whether there is volume overload, there sinus rhythm with LBVV, or what is the etiology, is it ischemic or not, is there atrial fibrillation, is there coronary artery disease, iron deficiency. So you have to find out what are the comorbidities, in what phenotypic group it is falling, and accordingly offer the specific treatment. For example, if it is in atrial fibrillation, you have to give Novax. Then if there is mitral regurgitation, there is evidence-based indication for doing MV repair, either surgically or transcatheter. Ivabradine has an indication where it is to be given. Then in selected advanced heart failure, you have to use either mechanical circulatory supports or heart transplantation as the therapy. This I am skipping because this was already covered. And follow-up is also very important. It should be done at least at 6 months in a stable case, and it should be interval should be shorter if there are indications or there is need for titration of the medication, and every visit ECG echo should be done. And the treatment of hypertension, use of statins appropriately, and the use of SGLT2 inhibitors in diabetic patients at high risk is class 1 indication for as a prevention. So self-monitoring and telemonitoring, these are the two things which are very much emphasized in the West. The patients are asked to take their weight, pulse, lung impedance, and blood pressure, pulmonary artery pressure activity. This is also being done in select cases in the West, where they put a device into the pulmonary artery which senses the fluctuations in the pulmonary artery pressures, and it is remotely monitored by the clinic, and they give telephonic advice as to how much diuretics are to be given. So these are the newer things which are coming up. To conclude, the concepts of heart failure with preserved ejection fraction, mildly reduced ejection fraction, advanced heart failure, and phenotypic approach, these are the things which are emphasized in the ESC guidelines. Natriuretic peptides and a good echocardiographic evaluation is a must in all the cases. And ARNI, RAC inhibitors, beta blockers, MRA, diuretics, and SGL2 inhibitors are the 5 pillars of the treatment. And now SGLI2 inhibitors are class 1 drugs. They are no longer drugs for the diabetologist, but they are the cardiac drugs of prime importance. And ARNI indications and usage is expanding. Versigot and ivabradine and digoxin have limited role. We should know where to use. And ICD, CRT, CABG, PCI, TAVI, and mitral valve repair in select cases. And self-monitoring and remote home monitoring are the strategies which are coming up. With this, my talk is over. Now we are open for discussion.
Yeah, thank you very much, Dr. Patnaik, for a nice presentation. So I think it's time to take a few questions. There are some questions which have already come up in the chat box. So Dr. Patnaik, if you can answer this, some of them. Okay. Okay, so just a minute. So one of the questions which has been raised by one of the participants is hyperkalemia and is hyponatremia a concern for using this ARNI?
Hyponatremia itself is a important concern when you are using diuretics. So when somebody is on stiff doses of diuretics, that is not the time to add ARNI. Once he is stabilized and is in a minimum maintenance doses of diuretics, ARNI can be introduced. So hyponatremia should always be monitored like hyperkalemia or hypokalemia. Yeah, it should be monitored in acute hospitalized patient.
Another question is, what's the ideal dosage in acute decompensated heart failure conditions in diabetic heart failure, and what's the dose titration during discharge? I think you addressed this. So starting dose for ARNI, and then what's the ideal dose?
There are two subgroups. One is those who are already on AC inhibitor or ARB. Another is naive. That means they were not previously on this AC inhibition. I already showed in my slides that you should start at 50 milligrams BD if the enalapril dose is about 10 milligram BD, or valsartan less than 160 milligrams, then you can use RNA 50 milligrams twice. Much lower dose is used if there is chronic kidney disease or if there are concern for hyperkalemia. Much lower dose can be used. In OPD, you will feel much more confident to use, but our starting dose is 50 milligram twice and up titrated after the 2-week visit to 100 milligram twice.
Okay, so there's another question. I think maybe Dr. Raju can answer this. Do SGLT2 inhibitors confer cardiovascular benefit beyond just heart failure? Is there any benefit in myocardial ischemia? Dr. Raju? Raju, okay, so Dr. Patnaik, you can take this question.
Hello?
Yeah, do SGLT2 inhibitors confer cardiovascular benefit beyond just heart failure? Is there a benefit in myocardial ischemia?
Basically, SGLT2 inhibitors, we know, have multiple benefits. One is it can produce natriuresis, reduce the dose of diuretics in patients with heart failure. So the role of SGLT2 as a cardioprotective or an anti-atherosclerotic is still controversial. So if we take the 3 atherosclerotic disease markers of stroke, MI, and amputation, SGLT2 has shown in some trials where the incidence of MI has been shown to be reduced, which was statistically significant. However, in relation to stroke and amputation, there was no statistically increased incidence or reduction in stroke or amputation. So it cannot be attributed to an anti-atherosclerotic property of SGLT2. Now, having said that, if you take nitrates, they reduce the angina by decreasing the preload on the heart. Similarly, Myocardial can reduce the preload on the heart, thereby reducing the angina. In the same context, SGLT2 can have an improved cardiovascular outcomes by reducing the preload because it is basically acts like a diuretic. So at this point of time, as an anti-atherosclerotic, the reduction in MI cannot be attributed to anti-atherosclerotic property of SGLT2. But it could be because of a decreased preload, we may have a certain benefit. However, this is a hypothesis generating thought that what would be the cause for decreased incidence of MI in these patients who are taking SGLT2.
Okay. So the other question is, what's the ideal dosage of RNA and SGLT2 in renal and hepatic impaired patients? Dr. Patnaik?
Yeah, actually, there is, you have to look at the GFR. Less than 30 of GFR, we don't give. If it is above that, it can be given. If it is less than normal and above 30, probably we can go for very low dose. Maybe initially half dose of 50 milligram in the morning and evening and watch the renal function, then up titrate slowly.
Okay.
What other thing, other faculty?
The hepatic. Okay, so I think that's it. More or less, these are the questions which have been posted here. So any further questions by anybody? Okay, so if there are none, I think we have already passed the scheduled time, and it's been a wonderful session where very concise and all the points have been covered in the treatment of heart failure, especially the role of RNA. I would like to thank CIPLA people for organizing this webinar, and all the speakers for sharing knowledge and then spending time to give these presentations. Thank you very much. Over to the CIPLA team.
Yeah. Hello.
Yeah.
Yeah. Thank you, sir. Thank you for wonderful session, Doctor. Especially Dr. Ramesh Gudapati, sir, and Dr. Ian Patnaik, sir, and Dr. PVR, sir, Dr. Naveen Krishna, sir, Dr. Jagadish Bob, sir. And thanks for attending attending this wonderful scientific session. Thank you, sir. Thank you, all.
Thank
Sir.
you.
With your permission, can we conclude, sir?
Yes, we can close the session. Thank you.
Thank you all.
Thank you.
Thank you. Thank you all.
Thank you, sir.
Bye.
Yeah. Radiance technical team, please wind up the section. Hello, Vikas, are you there? Vikas from Radiance.
Yes, sir. Yes, sir.
Yeah. Please wind up the session, please.
Okay, sir. Okay.
Thank you. Thank you.
Recording stopped.